Hello everyone, welcome to this final crash course series session on general surgery, and this is part 2 of our general surgery session. If you want to find out more about our teaching, please give us a follow on Instagram. The link is in the top right hand corner of the screen there. And if you want to get in touch with us and ask any questions about our teaching sessions or to get involved yourselves, then the email address is down on the bottom left. So we'll make a start. The link to the polls this evening is via VBox, so if you want to scan the QR code, you can get involved in the poll. Question 1. 76-year-old man attends A&E with 2 days of vomiting and absolute constipation. He feels generally unwell and he also has hiccups. On examination, he has a hard, tender, irreducible lump in his left groin, and his bloods are as follows. What's the next appropriate step in management for this man? So the correct answer to that question was E. So it would be open emergency repair, and I'll go on to explain why. So this gentleman has an inguinal hernia, and an inguinal hernia is abdominal contents, so for example bowel or intra-abdominal fat that have entered the inguinal canal, and they can do this via a direct or an indirect approach. Inguinal hernias make up 75% of all anterior wall abdominal hernias, and direct inguinal hernias enter the canal due to weakness in the posterior wall, also known as Hasselbalch's triangle. And this is due to increased abdominal wall laxity, for example, with increasing age, or increased pressure, for example, obesity. Indirect inguinal hernias make up 80% of all inguinal hernias. And in this case, the contents enter via the deep inguinal ring, and this is due to incomplete closure of the processus vaginalis during early development. Indirect hernias are found lateral to the inferior epigastric vessels, whereas direct hernias are medial to the vessels, and this is discovered during surgery. Symptoms of an inguinal hernia include a groin lump with mild to moderate discomfort. And what we want is for this lump to be reducible. So it will sometimes come in or come out depending on the position that the patient is sitting or standing or lying in. And it should be easily reducible once it's pressed in. However, problems with these, they may become incarcerated, which means that they're unable to be pressed back inside the abdomen, or worse, they may become strangulated. So this is where they've been incarcerated for some time, and this has compromised the blood supply due to swelling, and this leads to risk of bowel ischemia. Management for inguinal hernias, generally, we can take a conservative approach if the person is not suitable or doesn't want surgery, and this involves watchful waiting, or sometimes if a hernia is very large and the person's not suitable for surgery, they can wear a groin truss, which is a special type of underwear to keep the hernia in place. For surgical repair, in the case of this patient in the question, he's got some raised inflammatory markers and raised lactate, which would suggest that there is some bowel compromise here. And in that case, it's got to be an open surgical repair. If the patient is found to have bowel ischemia, then we don't use mesh. However, if we get in there and the bowel is viable, then we can use mesh. If there is ischemic bowel or any signs of peritonitis, then that bit of bowel will need to be resected as well. So here is a table just differentiating between direct and indirect inguinal hernias. So direct inguinal hernias are uncommon in children. They're acquired, so they're often found in older people. They're medial to the inferior epigastric vessels. They rarely descend into the scrotum. And they have a wide neck and rarely strangulate. And the treatment for these is open mesh, or sometimes they use laparoscopic repair, depending on the skill of the surgeon or the speciality of the treating hospital. In indirect inguinal hernias, they are often found in young people, but they can be found in any age. They are congenital in their etiology due to a patent processus vaginalis. They're lateral to the inferior epigastric vessels. They frequently descend into the scrotum. The neck of these is narrow, which means they're more likely to strangulate and so need fixing earlier. And in infants, they can be treated via a herniotomy, which is ligation and excision of the hernia sac. And in adults, it's a similar treatment to a direct hernia, an open or laparoscopic surgery using mesh. And here is just some useful terminology in regards to hernias. And this does not just apply to inguinal hernias, but to other types of hernias as well. So if a hernia is reducible, it means that the contents can be fully restored to the abdominal cavity, either spontaneously, so they'll just pop back in as the patient moves position, or they can be pushed back in. If a hernia is incarcerated, then part or all of the contents cannot be reduced, and this is usually due to a narrow neck of the hernia or adhesions, and there's a high risk of strangulation in this case. If a hernia is obstructed, this means that it contains an obstructed loop of bowel due to kinking of the bowel, and this usually goes on to strangulate. And it would also cause symptoms of bowel obstruction, such as vomiting and constipation. If the hernia is strangulated, then that means that blood supply to the sac is cut off, and the tight neck usually causes the bowel to strangulate. The terms with the stars next to them are referred to as complicated hernias, but a reducible, ongoing sort of chronic hernia is often uncomplicated. The pathology behind strangulated hernia leading to bowel ischemia is venous or lymphatic occlusion, which leads to edema and increased venous pressure. This then impedes the arterial flow and leads to bowel necrosis and possibly perforation if it's not caught in time. Question 2. A 72-year-old woman is referred to the acute surgical unit for assessment. She's complaining of generalized abdominal pain, which is worst in the epigastrium, but she also has pain in the left iliac fossa. And on examination, her abdomen is soft but diffusely tender, and her VBG shows the following. What is the most likely diagnosis in this lady? So the answer here is C, ischemic bowel. Ischemic bowel disease can be divided into 3 types. Acute mesenteric ischemia, which can in itself be divided again into embolic, thrombolic, or venous disease, chronic mesenteric ischemia, or colonic ischemia. And symptoms are similar in that they all involve abdominal pain, which is often out of proportion to the clinical findings. So in this lady, she's got kind of vague abdominal pain that doesn't really match up with a particular pathology. Diarrhea, vomiting, bloody stool and vomit can also occur. And if it's chronic, can cause weight loss and malabsorption of nutrients. Patients often have other vascular risk factors. So to investigate these patients, we want to do bloods, particularly looking at lactate for any signs of bowel ischemia. An erect chest X-ray will be useful if we're suspecting any pneumoperitoneum or bowel perforation. And then ultimately a CT scan with or without an angiogram will show you colonic thickening, pneumatosis intestinalis, or intramural gas. And if we do an angiogram, we can hopefully see the blood supply of the vessels as well. Surgery for ischemic bowel disease involves embolectomy plus or minus resection of non-viable bowel in acute SMA occlusion. In the case of mesenteric vein thrombus, we will do anticoagulation and consider surgery with thrombectomy and resection for compromised bowel. And sometimes the disease is so bad that it affects the whole colon, and this is called fulminant ischemic colitis, and the treatment for this is either a subtotal or a total colectomy. Question 3. A 26-year-old patient attends the surgical assessment unit with right iliac fossa pain and pyrexia. On examination, they have increased tenderness in the right iliac fossa when the left iliac fossa is palpated. What is the name of this sign? So the answer to this question is C, it's Rovsing's sign. So this patient has appendicitis, which is inflammation of the appendix, usually due to blockage by a fecalith, a hard lump of stool. This then leads to bacterial stasis within the appendix and subsequently inflammation and swelling with impaired venous drainage, and this leads to ischemia and possibly gangrene. Appendicitis is usually a clinical diagnosis, however we can use imaging if we're in any doubt. This is particularly useful in young children. The patient is likely to have raised inflammatory markers, a low-grade fever, and it's also important to consider other differentials, particularly in young children. So over COVID-19, a lot of young patients had mesenteric adenitis, so swelling of the lymph nodes within the abdomen that causes similar abdominal pain. But these children will not have particularly raised inflammatory markers. They will often have quite a high grade pyrexia, especially if they have COVID. The management for appendicitis is most frequently a laparoscopic appendectomy, plus antibiotics if there's any perforation or any abscess developing. And complications include a ruptured appendix if it's not caught in time, which can lead to fecal peritonitis or abscess formation. So as we've said, it's important to consider other presentations, particularly in younger children. Young children can be hard to examine and they can find it hard to localise where their pain is coming from, particularly if they're non-verbal. So you can rely on your clinical signs, such as your psoas sign, raising their right leg, and that increases the pain. Rovsing's sign, which is pressing in the left iliac fossa, that increases pain on the right, and any localised guarding. Features favourable for appendicitis include a moderately raised white cell count and CRP, low-grade fever, a pain that starts centrally and migrates to the right iliac fossa, and positive psoas or Rovsing's signs. Other diagnoses to consider include change in bowel habits, so constipation, for example, a very high fever, which might be indicative of a viral infection, such as COVID-19, or a water infection, such as a UTI. And you can always consider an ultrasound abdomen if you're unsure of a diagnosis in a young child. Here are some useful definitions of different signs that you might come across. So Murphy's sign is pain on inspiration when palpating the gallbladder and often indicates acute cholecystitis. Rovsing's, obturator's, psoas and McBurney's signs are all related to appendicitis. Courvoisier's law is a painless, palpable gallbladder that is unlikely to be gallstones, i.e. it may be something more sinister, such as pancreatic malignancy. Cullen's sign is periumbilical bruising, and it's often a late-stage sign that is indicative of hemorrhage from pancreatitis or a retroperitoneal hemorrhage. Gray-Turner's sign is bruising on the flanks and can be indicative of pancreatitis or a ruptured AAA. Question number 4. 65-year-old woman presents to A&E with vomiting for 3 days. She has absolute constipation. She has no fever or weight loss. Her past medical history includes a hysterectomy and BSO after she's finished having her family, and Crohn's disease that's currently well controlled on biologic medication. On examination, she has a descended abdomen, it's tympanic on percussion, she's got hypoactive bowel sounds, and there's no obvious masses. What's the most likely cause of her presentation? So the answer in this case is C, adhesions. So this lady is suffering from a small bowel obstruction. Adhesions are the most common cause for small bowel obstructions in the UK, over 80%. And even though this lady has Crohn's disease, we know that it's well controlled on biologics, so that makes it less likely compared to her other risk factors, which include major abdominal surgery in the past. Causes of small bowel obstruction include adhesions, hernias, active inflammatory bowel disease or malignancy. You can also have pseudo-obstruction, where, for example, someone has massive constipation or ileus after surgery. And this is not a physical blockage, but it's a, ileus, for example, is a slowing down of the bowel's peristalsis that leads to obstructive type symptoms. Symptoms of small bowel obstruction include nausea and vomiting, absolute constipation, which means that they're not passing flatus or stool, abdominal pain, and they often have hiccups. There may be signs of sepsis, for example, hemodynamic compromise or fever, if their bowel is perforated. Investigations include taking a full set of bloods, a VBG or ABG with particular interest in the lactate. We can do an abdominal X-ray, and ultimately we'll end up doing a CT abdo-pelvis. Here on the right, you can see the classical picture of a small bowel obstruction on an abdominal film. You can see the distended loops of small bowel with the lines going right across the small bowel. And if we were looking at a large bowel obstruction, for example, these lines would only sort of partially cross over the bowel. The small bowel should only measure 3 centimetres or less. So if you measure and it's more than that, then we know that it's dilated. And the bottom image shows a bowel after a patient has had gastrographin. So as part of our management, conservative management strategy can include inserting a Ryle's tube to decompress the stomach, give some anti-sickness, and give some gastrographin down the NG tube. This gives us a clearer image of the obstruction and the transition points, but it can also be therapeutic, and it can actually release the obstruction in some patients. However, if it doesn't work, the next option would be adhesiolysis plus or minus resection of compromised bowel. Question 5. 6-year-old man presents to A&E with vomiting, rapid weight loss and jaundice. He has a palpable mass in the epigastric region. He reports pale stools and dark urine for the last 2 weeks. What condition is associated with his diagnosis? So the answer to this is A, new onset diabetes. This patient is most likely suffering from pancreatic cancer, which is most commonly adenocarcinoma of the head of the pancreas. It usually presents late with painless jaundice, and there may be accompanying symptoms of gastric outlet obstruction if there is progression of the tumour, for example, vomiting. If the tumour has invaded into the vasculature, it is unfortunately non-operable. Blood tests may show deranged LFTs, an obstructive picture, and a raised CA19-9. For stage 1 to 2 disease, which has not invaded the vessels, we can consider a Whipple's procedure, and there's a diagram of that here on the right. In stage 3 or higher, non-operative management is used, for example, stenting of obstructions, chemo or radiotherapy, and pancreatic enzyme replacement. For worse than new onset diabetes in a person who has not got other risk factors, as it can be an early sign of pancreatic cancer. A 27-year-old patient with a history of inflammatory bowel disease attends A&E with frequent episodes of bloody diarrhea up to 10 times a day. She is pyraxial and tachycardic. She has lost 4 kilos in weight over the last several months. Which scoring system is used to assess severity of an acute flare of ulcerative colitis? The answer to this is D, it's true love and wits. So Glasgow Imrie classification is used to classify pancreatitis, and Blatchford and Rockall scores relate to GI bleeding. Inflammatory bowel disease, and we will here focus mainly on surgical management. So true love and wits criteria is used to assess severity of ulcerative colitis. And the first medical treatment would be IV steroids, IV immunomodulators such as cyclosporin, or TNF alpha such as infliximab, and surgical options if these fail. Ulcerative colitis and Crohn's disease are both forms of inflammatory bowel disease. Ulcerative colitis affects the large bowel, it's confined to the mucosa. Microscopically, we can see crypt abscess formation, reduced goblet cells, and it's non-granulomatous. Macroscopically, we see continuous inflammation when scoping, which proceeds up from the rectum around the large bowel. We may also see pseudopolyps and ulcers. In Crohn's disease, the disease affects the entire GI tract or any part of the GI tract from mouth to anus. There is transmural inflammation. There are granulomas found microscopically, and macroscopically on scoping, we see skip lesions, so sections of inflamed bowel with healthy bowel in between. There may be fissures and deep ulcers, which are sometimes described as cobblestone appearance. There can be fistulas and also strictures, so narrowing of the bowel. And here is an overview of different surgical procedures done for inflammatory bowel disease. So in UC, a subtotal colectomy and ileostomy are often done in an emergency situation. So if a person's having a very severe flare that's not responsive to medication, and the rectum is removed at a later stage. And from that point, the patient can either have their rectum removed and a permanent end ileostomy formed, or they can have an IPAA, an ileal pouch anal anastomosis. And this is a pouch made out of small bowel, which is attached to the anal sphincter, and it allows the patient to be continent without the need for an ileostomy. For Crohn's disease, there's various different sorts of surgery, although it's worth reminding that Crohn's disease can't be cured by surgery, and so surgery is will be used as a last resort for particularly active areas of disease. There can be a stricturoplasty, so strictures that are opened lengthways to widen the intestinal lumen, and this preserves the bowel. If a stricture is particularly bad, it can be resected with the healthy ends joined as an anastomosis, although Crohn's disease often tends to occur at anastomotic sites. In an ileocecal resection, the terminal ileum and the cecum are resected and the small and large bowel are joined back together. You can have a partial hemicolectomy or sometimes a subtotal or panproctocolectomy with an ileostomy, and this leaves a permanent stoma. A 30-year-old woman attends the surgical assessment unit with pain around her back passage. She says the pain is worse on passing stool and she's been avoiding going to the toilet as a result. She's noticed some bright red bleeding in her stools. What's the most appropriate first-line management? So the answer is A, topical GTM. So this lady likely has an anal fissure. And some of you might wonder why the answer would not be E, because fissures are often caused by constipation and straining. In this case, I would argue that A is more appropriate because this lady's pain is bad to the point that she's avoiding going to the toilet, which is only going to worsen her symptoms. So whilst dietary advice is important in managing further fissures from forming, she needs some treatment at the moment to help. And this table just sums up the different type of anal lesions that are common and you might find in your exams. So for an anal fissure, it often presents a sharp pain on passing stool, which can last for a couple of hours after a bowel movement, and it's often associated by constipation and straining. But then adversely, once the patient has a fissure, it can actually make their constipation worse because they avoid going to the toilet due to pain. First line management is topical GTN cream or diltiazem, and complications include a non-healing chronic fissure. Hemorrhoids are swellings around the opening of the anus, and they're not usually painful. They may be uncomfortable or itchy, and they're more comfortable in constipation or in pregnancy. For external hemorrhoids, we can use topical hydrocortisone or banding. And complications include thrombosed hemorrhoids, which can be very, very painful. And often patients will come and seek acute care and ask for the thrombosed hemorrhoid to be removed. But unfortunately, the answer to this is a watch and wait approach. The hemorrhoid has effectively banded itself, and it's about getting the patient comfortable for a few days while that hemorrhoid dies away. They can also bleed as well. Pilonidal cysts are swellings at the top of the nasal cleft, and they're managed often conservatively, so hair removal, keeping the area clean. However, they can develop into an abscess, plus or minus systemic illness, in which case they need an incision and drainage. And there's also perianal abscesses. So these are pain and swelling adjacent to the anus. It's often uncomfortable to sit down. The patient can have signs of generalized infection as well. It's often treated first line with antibiotics, but it may also need incision and drainage. It's more common in patients with inflammatory bowel disease, and they can develop into fistulas. A slightly different topic. Which of these is an example of wound healing by secondary intention? So the correct answer to this question is C. Answers A and B are examples of wounds healing by primary intention, as they're closed in theatre. Whereas C, the pilonidal abscess has been washed out in theatre and packed with gauze. So healing by secondary intention means that the wound is healing from the base of the wound upwards. And our last question of the evening, question 9, what classification of wound contamination is correct? So is a clean wound urgent or emergency surgery or elective opening of the GI-GU biliary tract with minimal spillage and no contained infection? Clean contaminated, is that definition correct? Contaminated or dirty? So the correct definition out of these is C. So a contaminated wound is gross spillage from the GI tract or penetrating trauma that's under 4 hours old. The definition in A, this is an example of a clean contaminated wound rather than clean. B, that definition is a clean wound, not a clean contaminated one. And a dirty wound is not just when a patient develops a post-surgical infection, but the correct definition is the presence of purulent inflammation, such as an abscess, or pre-operative perforation of the GI, GU, or biliary tract, or penetrating trauma that is over 4 hours old. These definitions are useful both in general surgery, but also in plastics. Thank you for joining our session this evening. If you could post any questions in the chat, I can happily answer those. Or if not, please can you fill out the feedback form? It's much appreciated. And we look forward to seeing you in the next session. Thank you very much.